All right. So I'm taking an opportunity to um, just test my mic. Let me know if you can hear me. Good. Hello, hello, hello. Thank you so much, Britters. Welcome back. Welcome, Pamela White. Welcome, Bianca. Miss Bianca. Someone saying loud and clear. I think that's Ms. Mills. I think so. All right. Welcome, JM. Welcome, Ms. Brenda. We're going to take a moment, maybe just a couple of moments, to allow a few more people to come in. And while we're doing that, I want to know, how comfortable are you with evaluation and management guidelines? The basics. The general coding guidelines. Go ahead, type in the chat. Okay, so thank you so much, Miss Dolly, for coming in. Hi, Yvonne. Hi, Liz. Hi, it's one cat. I think I'm saying it wrong. Sorry about that. Good morning, good morning, morning. And someone said, hey, I need a refresher. Somebody said, I'm okay. I'm comfortable. Okay, that's what I like to hear. I'm ready. I hope you are too. Let's get started. Welcome to our presentation on evaluation and management guidelines. This is part three, not the part three that you're accustomed to. This is the new part three. And in this section, we're going to talk about guidelines. But first, we're going to read our copyright. CPT is copyright of the AMA. Keyword concept, FTR, Chun, AMCI Fab 7, AMCI ICD 10 CM Flip Tap, and MCG are registered trademarks of AMCI. The following credentials are owned by AAPC, CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, and AMCI does not own the rights to these credentials or the credentials owned by AHIMAs, CCA, CCS, CCS-P, RHIA, or RHIT. And the goals of this presentation are, number one, we are going to nail the guidelines for new versus established patients and initial versus subsequent visits. Number two, we're going to talk about the guidelines for split and shared visits, multiple E&M services on the same day, and finally, services reported separately. And again, we're going to be talking about guidelines. Even though we're talking about guidelines, you will have scenarios to test your knowledge. Now, coders, when you open up the evaluation and management section, you're going to come right here, the table of contents. And this blue box surrounds everything that we're going to talk about today, right here. So if you want a reference point, here you go. And let's get started with the guidelines on the green pages. And the main points of the E&M guidelines overview and classifications of evaluation and management services, the services, these guidelines primarily pertain to these locations in your book: the office or other outpatient services, telemedicine services, hospital inpatient and observation care services, consultations, ED visits, nursing facilities, home or residence services, and finally, prolonged service with or without patient direct contact on the date of an E&M service. So these green page guidelines pertain to these locations of service and locations in the book. Now, when we get up here and see where the black box is, it tells you to check the guidelines at every section. So every time you go to a section, if you're coding for office and outpatient, there may be guidelines directly underneath that heading. Read them. Any section, any new section foreign to you, read the guidelines. These guidelines tell you to read those guidelines. Also, in this section to the right, it tells you that these E&M services are classified to categories and subcategories, most of them. So when you go to the office and outpatient section, you're going to have a new patient and an established patient category. And maybe, excuse me, the category is office visit, and the subcategories are new and established. When you go to consultations, that's your category. Your subcategory will be office consultations or inpatient consultations. So just be mindful of that. And over here, this tells you that the codes will be based on the level of E&M service. Now, all of the codes are not considered that way, but some are, and you'll need to determine the E&M level of service. Also, time versus medical decision making will often determine your E&M code. And finally, down in this section, the place of service, well, that is the place that the service was rendered. Okay. Oh, here also face-to-face encounters. Face-to-face encounter is defined in this section as well. And it's basically when the provider carries out the service face to face. All right, so I'm going to take a look in the chat and see if you all have any questions. I don't think you do. I think most of you kind of knew these. Now, let's get to the nitty gritty. I'm going to kind of pick up the pace because a lot of you know the difference between new versus established patient, right? Basically, this is the status of the patient. It's also one of those subcategories that we've spoken about. And it's important that you identify the status of the patient. And a new patient is defined as anyone who was not seen in 3 years. If you weren't seen within 3 years, you are new. And yes, that's someone that's new to the practice, right? An established patient is anyone that was seen within 3 years. And that's important to remember. Okay. And the first box is where you can find that definition. Now let's turn our attention to this second green column in the black box. It talks about exact same specialty and subspecialty requirement. I'm not going to talk about it right now. I'm going to talk about it very quickly after this, but exact same specialty and subspecialty is required. Also, when we're talking about on call or covering for, remember The doctor who is being covered for, well, I'll put it this way. The doctor who is covering for will have the same classification as the doctor they are covering for. So if a general practitioner, let's say it, yeah, I'll say it like this. If a general practitioner is covering for an oncologist, that general practitioner will have the same classification when it comes to new and established patients, whether that general practitioner has seen that oncologist patient or not. Also, when you have an advanced practice nurse or physician assistant, some classification they have the same classification as the physician they are working with. Now, I'm going to run through these, but I will definitely give you examples of all of this, and it's going to make sense. Also, there's no distinction when a patient's in the ED, whether it's new or established, right? So there's no new or established classification for the ED, right? Right. You're not an established, you can never be an established emergency department patient, right? Okay. So, and finally, this guideline tells you to use the decision tree to determine the exact same specialty and subspecialty. And I'm going to talk about same specialty and subspecialty, but first, I have a question for you, coders. What is the most fundamental evaluation and management guideline? What is the most fundamental evaluation and management guideline? And I'm going to give you a clue or a hint. It begins with 1. Type your answers in the chat. 1. Come on. 1. E&M. Okay, someone said, hey, it's not. Okay, I'll say it. Have you heard this? 1 E&M code per doctor per day? Type in the chat. 1 E&M code per doctor per day. This is the basic and most fundamental E&M management guideline. And I'm telling you, it means that you can only code 1 E&M code per doctor per day. Wow, someone said they never heard that. Okay, well, you know what? This might, it's okay. We're going to learn it today. So, CPT has expanded upon that guideline, and now it's 1 E&M code per group practice per day. Yeah, you can only code 1 E&M code per group practice per day. So, in essence, all members of the group must have the same specialty and subspecialty. So that's not necessarily true, but it's 1 E&M code per group practice of the same specialty and subspecialty per day. And I'm going to let that marinate. And while we're doing that, I have an example for you. If you have ABC primary care group, right? And Dr. A is an internist, and so is Dr. B. They're both internists. However, they are not the exact same because Dr. B has a subspecialty in oncology and Dr. A does not. So, if either of these doctors see the same patient on the same day, both can code them and they can also code possibly initial visits. Right? Because they're not of the same specialty and subspecialty. And if you just want to know what subspecialty is, well, internists, they specialize in internal medicine, but Dr. B went on, got some more education, and he is oh, wait, what happened here? I think I got a little, all right, and he um, got more education and he has a subspecialty in oncology. Sorry about that. Now, the guidelines tell you to use this new and established patient chart to or decision tree to determine if the patient is new and established based on that subspecialty and specialty rule, right? So if you locate the decision tree in your E&M manual, you'll find that it says at the top, it's asking if the patient has received professional services from the physician or other qualified healthcare professional or another physician or other qualified healthcare professional in the same group of same specialty within the past 3 years. You're going to need to answer this question. Has this patient received any services from anybody in the practice within the last 3 years? If you say yes, then if it pertains to anyone else in the practice, if it's anyone else in the practice, you have to determine if it's the exact same specialty. If they are of the same specialty, if you answer yes, you just follow the decision tree along. If you answer no at any time, it's a new patient. All right. So maybe it's better to give you some examples to test your knowledge and enable you to use this decision tree to get the answer. I think that works for me and hopefully it works for you. But basically, if you can answer no to any of these questions, then it's a new patient. If all of the answers are yes, then it is an established patient and all do not apply. So if it applies and you say yes, it's established. And if you can say no, it's a new patient. All right, so it's time to test your knowledge on new and established visits. Okay, coders. Mary is a stay-at-home mom. She arrives for a follow-up visit to manage her hypertension. Her last visit was 3 months prior. What say you, coders? Is this a new or established patient visit? Now, someone asked a very good question. If they're in the same group, they can't, right? If they are in the same group, you must have the same specialty and subspecialty to be considered. If you don't, then you're either new or it could be initial visit. That's the next conversation. Exactly. So the answers are coming through, and here are my keywords. We have a follow-up visit, and she was seen 3 months prior. So absolutely, she is an established patient. You really don't have to use this chart, but let's go ahead. So we're answering the question, Has she received any services within the last 3 years? And the answer is yes. And that's as far as we can go. And if you can say yes to everything that's applicable, that is an established patient. Way to go, way to go, way to go. Outstanding. Yes, she was seen within the last 3 years. Okay, now we got another one. Joan has a history of Graves' disease and has been managed by Dr. Brown quarterly, who was an endocrinologist at Capital Endocrinology. Dr. Brown recently resigned, and Joan is here to see Dr. Williams for the first time. Dr. Williams is also an endocrinologist in the group practice. Okay, coders, is this a new or established patient visit? Type your answers in the chat. Some of you are coming through so quick. Outstanding, outstanding. Good job. I'm saying good job because you're answering. I'm not letting you know what the answer is, though. But great job, great job, great job. And a lot of you said established. Let's go ahead and work this. We have Dr. Brown. And we also know that he's an endocrinologist. But Dr. Brown resigned, and she's been managed by Dr. Brown quarterly, right? So she's been seeing this doctor. Now, Dr. Williams is basically taking over Dr. Brown's practice and or patients, and Dr. Williams is an endocrinologist also. And this is the first time that Joan is seeing Dr. Williams. So you know what I'm going to do? I'm going to use this decision tree. And it's asking me, has Joan seen any doctor within this group practice of the same specialty within the last 3 years? And that answer is yes, because she saw Dr. Brown. Even though Dr. Brown resigned, she saw him. So is it the exact same specialty? We can say yes, they're both endocrinologists. Are they exact same subspecialty? Well, neither of them have subspecialty, so we can say yes. And you know what? This is an established visit. You all didn't even need this, did you? Outstanding. Someone said this is the same patient because they're in the same group practice. Not quite. It must be the same. They must have the same specialty and subspecialty. Outstanding. All right. Now we have Tom, who's a fifth-year senior at Massachusetts College and is home for Christmas break. While home, Tom decided to set up an appointment with his family doctor, who managed Tom's care since infancy. Tom's last visit was when he was a freshman in high school. Okay, coders, is this a new or established patient? Type your answers in the chat. Outstanding. You're answering. Well, I'm going to do my due diligence. What's a fifth-year senior? Well, it means they were in school for 5 years, right? And Tom's last visit was a freshman in high school. So maybe he hasn't seen this doctor for about 8 years, right? So has he received any has he seen any doctor in this practice within the last 3 years? And the answer is no. So, Tom is a new patient because the visit was more than 3 years. Way to go, way to go, way to go. All right, we got another exercise. We have a 4-year-old female patient who presents to the clinic on a Saturday afternoon with complaints of shortness of breath and chest tightness. The physician is on call is Dr. Brown, who is a cardiologist, covering for Dr. Arowitz, an internist, who is the patient's regular physician in the same group practice. Dr. B reviews the patient's history, medications, and past encounters in the group's EHR, and Dr. B performs a detailed exam and orders diagnostic tests to rule out acute coronary syndrome. Okay, coders, is this a new or established patient visit? What say you? Good job. You all are answering, and that's what I want to see. Don't be afraid to answer these questions. All right, coders. So, the first thing that you need to draw your attention to is the words covering for. Anytime you have covering for this decision tree for new and established patients, it's not applicable. You're going to have to go and grab the covering for guideline. And the covering for guideline says, hey, the doctor who is covering for has the exact same status as the doctor they are covering for. So, Dr. Arowitz is the patient's main doctor. So if it's the patient's main doctor and they have an established, and it's Dr. Arowitz is an established visit, then Dr. Brown is an established visit as well. You all with me? All right. Now, let's move on. I think you did a fabulous job. I think you, for the most part, you understand new and established patients. And remember, new and established patients, that describes the status of the patient or the status of the visit. That's better. Now, when you have initial and subsequent visits, this is the type of encounter. What type of encounter? And typically, when you have initial and subsequent visits, it's pertaining to visits inpatient, typically. Now let's go ahead and review the guidelines' main points. If you turn to initial and subsequent services in your CPT, the main points are the definition of initial inpatient visit is anyone not seen by a physician or qualified healthcare professional of the same specialty and subspecialty who belongs to the same group practice during an admission. Basically, we can just nail that. We can just refine that. It's anyone not seen by the physician or seen by anyone in the group of the same specialty and subspecialty. Also, covering for has the same classification as the provider being covered for. And number three, this is important. Advanced practice nurses and physician's assistants have the same classifications as the physicians they're working for. Number four, anytime you transition from observation to inpatient, it's the same. So, not much different than new and established, but only we're talking about inpatient visits, right? Which one is initial and which one is subsequent, right? So initial means that this is the first visit and they were not seen by anyone in that group of the same specialty and subspecialty. Oh, and here's another one. Nursing facility, transitions within the facility are considered the same stay. And yes, nursing facility is an inpatient facility as well. Now, it's time to test your knowledge of initial and subsequent visits. And remember this guideline, coders. There is one E&M visit per practice of the same specialty and subspecialty per patient, per condition, per day. Maybe I introduced that too soon, but this is the guideline. Now let's go ahead and test our knowledge of initial and subsequent visits. Of the following answers, which best describes Dr. Brown's encounter? A, 99221, B, 99222, C, 99223, and D, 99231. A 72-year-old male is admitted to the hospital with pneumonia. On the day of admission, Dr. Green, an internist, performs a full history exam and initiates treatment. The following morning, the patient is evaluated by Dr. Brown, who's also an internist in the same group practice covering for Dr. Green. Dr. Brown documents the progress of the pneumonia, reviews lab results, and makes adjustments to antibiotic therapy. Okay, coders. What type of encounter is this? You all are, someone is knocking it out. That's what I'm talking about. Don't be afraid to answer these questions. Go for it. Okay. All right, so we are going to follow the initial and subsequent services. And what we need to answer? We need to answer, is Dr. Brown the same as Dr. Green? Is Dr. Brown in the same group as Dr. Green? Is Dr. Brown in the same group as Dr. Green? Yes, he is. Is Dr. Brown of the same specialty as Dr. Green? Yes, he is. They're both internists. Is Dr. Brown and Dr. Green of the same subspecialty? Well, it just says they're internists. They don't have a subspecialty, so we're going to say yes. They both have none. So if we answer yes to all three, this is an established patient. Yes, well, someone said because he's covering for him. I definitely agree with that as well. He's also covering for him, but it's an established patient, right? So, subsequent hospital, inpatient, or observation care. I'm honing in on this, right? So if it's established, that means that it's possibly a subsequent visit. Possibly, right? Because you should not have been seen you should not have the same specialty and subspecialty and have been seen, right? So Dr. Brown saw the patient, but Dr. Green saw the patient first. And if Dr. Green saw that patient first, this is a subsequent visit. 99231. So 99221 is an initial visit, 2223, all initial visits. And your answer is D. Now, you know what? I think the question was asking, hey, is this an initial or subsequent visit? I think we need to, excuse me, they were asking if it was a new or established patient, I think. Was it? Doesn't look like it. So don't confuse the two because I may have misspoke. I may have misspoken. So the goal here, the objective is to determine if this is an initial or subsequent visit. And the guidance says that it is an initial visit is the first visit from anyone in that practice for that encounter, for that admission, right? So the patient was already seen by Dr. Green on the day of admission. And Dr. Brown, even though it's the next day, because they are of the same specialty and subspecialty, it is a subsequent encounter. So hopefully you understand that. All right. Now, here is another scenario, but this one is asking you, of the following answers, which best describes Dr. Lopez's and Dr. Singh's encounter? So we need to know how we're going to code for Dr. Lopez and how we're going to code for Dr. Singh. A 68-year-old female is admitted for uncontrolled diabetes with sepsis due to a urinary tract infection. On the day of admission, Dr. Harris, a hospitalist, performs the initial comprehensive exam, reviews labs, and begins IV antibiotics. Two days later, Dr. Lopez, an endocrinologist from the same group, is consulted to evaluate the patient's diabetes management. On the same day, Dr. Singh, another hospitalist from Dr. Harris's group, also sees the patient to assess her sepsis status and continue inpatient care. All report high MDM or high medical decision making. So, which is the best of the four answers? A. Dr. Lopez will report 99223, Dr. Singh 99231. B. Dr. Lopez will report 99233. Dr. Singh will report 99232. Dr. Lopez will report 99221. Dr. Singh will report 99231. Dr. Lopez will report 99221. Dr. Singh will report 99223. Okay, coders, I'm going to give you an opportunity to look up these codes. But first, let me give you a hint. You're going to have to determine if anyone is initial or subsequent visit. And while you're putting your answers in the chat, someone said, how do you search this in the index? You don't search in the index. You don't have to because it's really a small area. You can go straight to the table of contents. You can and look for the location. So if you're coding for an office visit, that's where you'll look. And there are probably only maybe about 5 codes there, and you search according to your keyword. So if you're searching for initial visit, then you would um, select a code from that range and so forth. All right, so we have a little mixture. Some people are kind of skewed between A and B, right? So let's go ahead and figure it out. This is how I process it. So we're going to compare Dr. Lopez and Dr. Singh to the credentials of Dr. Harris because he performed the initial comprehensive exam, right? All all three are of the same practice. So we need to know, is Dr. Lopez of the same group as Dr. Harris? Well, we just said yes, right? Is Dr. Lopez of the same specialty as Dr. Harris? And Dr. Harris is a hospitalist, Dr. Lopez is an endocrinologist, so no. Is Dr. Lopez and Dr. Harris of the same subspecialty? And that answer is not applicable. Neither of them have subspecialties. Now, when we turn our attention to Dr. Singh, is Dr. Singh in the same group as Dr. Harris? Yes. Are they of the same specialty? Yes, they're both hospitalists. Is Dr. Singh the same? Does Dr. Singh have the same subspecialty as Dr. Harris? Well, it's not applicable. None of them have subspecialties. So, Dr. Lopez, because Dr. Lopez is not of the same specialty and subspecialty as Dr. Harris, Dr. Lopez can record an initial visit. Whereas Dr. Singh is of the same specialty and subspecialty as Dr. Harris, so therefore Dr. Singh reports a subsequent visit. I'm going to let that marinate. And I see Miss One Cat, she is just saying, hey, I'm going to go out on a limb and I'm going to do something different. Well, let's see what you've done. All right, so we know all of them have these high medical decision-making visits. We know Dr. Lopez, we have to report that initial high visit. Dr. Singh, a subsequent high visit. So let's do our due diligence. Under the initial section, as you can see, there are only 3 codes. Initial hospital or observation care of high-level medical decision-making. So this will be the code for Dr. Lopez. And if we know 99223 is for Dr. Lopez, we're going to get rid of B because this is 99233, not 223. So anything not coding for 99223 is incorrect. So both B and D are incorrect. Now, what will determine the correct answer will be the second code. How are we coding for Dr. Singh? And let's go locate the high subsequent visit code, and you can find it on the next page, 99233, subsequent hospital inpatient visit with high medical decision making. So the second code for, and that's coded for Dr. Singh, will be 99233. So we're going to eliminate B, and C will be our answer. And for those of you that couldn't see, I put the code, the visual up, I've made it bigger so you can see it. And 99223, this is your initial visit of high MDM. 99233, subsequent visit of high medical decision making. So if you said C, outstanding. And if you learned something, that is priceless. How are you doing, coders? Vina D said C. Jolicia, Anu, Yeida. I hope I'm saying your names right. Outstanding. All right, let's continue, right? All right, so we're still talking about initial visits and subsequent visits, and we just want to summarize things. And I think the most important thing to know is the definition of an initial inpatient visit means you weren't seen by any physicians in a group practice that have the same specialty and subspecialty during that admission. Okay, outstanding. And don't forget these other covering for guidance, your advanced practice nurses, and your transitions from observation to inpatient and nursing facilities. Nursing facilities are considered inpatient. Now, it's time to switch gears. You all ready? We got new and established and subsequent and initial visits out of the way. Let's talk about shared and split visits. I don't think we've ever discussed this. AMCI has. So this is the first time. So if you turn to the split or share visits guidelines, the main points are this. In the event physicians and qualified healthcare professionals work together during a single encounter, you're going to need these guidelines. Now, let's really hone in on what is a qualified healthcare professional. A qualified healthcare professional is an advanced practice nurse, not an LPN, not an RN, but a nurse that has advanced level education. So a nurse practitioner, okay? Also, physician's assistant. That is also a qualified healthcare professional. All right. So basically, sometimes these doctors and QHPs, they work hand in hand, and we don't know who to code for. Here's the guidance. If one person does the substantive portion of the visit, they report the service. So whoever does the most substantive, not who does the most, but who has the most impact on that encounter. Also, this one's straightforward. If the code selection is based on time, the provider who spends the most time will report the service. And that's straightforward, right? Okay, so I want to get back to that substantive portion of the encounter. Well, we're novice. We don't know what's substantive and what isn't, what counts as having the most impact on that encounter, but they give us some guidance here. It says when some of you haven't reached the part where you're learning about problems, data, and risk. But a lot of you should already know about problems, data, and risk. And basically, they're talking about problems, data, and risk when they're talking about this substantive portion. They want to know who carried out more of the PDR. Pretty much. Pretty much. Not all of it. You can use your discretion. However, when you have problems, the number and complexity of problems addressed at the encounter, it basically says whoever takes responsibility for this plan, not plan, whoever carries out any of these, this will be considered. Whoever carries out any of these data, like they review and order tests, this factors in. Whoever is takes responsibility for the risks of morbidity, whoever's writing those scripts at the end, that's it. So I don't have time to explain this PDR chart, but many of you know what it is because we've discussed it in week 8 of the YouTube course. We discussed it in week 8 of the AMCI part 3, and you should know it. But if you haven't gotten there, just chill a little because you're going to get it. Okay, so just trust me on this one. All right, so basically, who does the more impactful amount of the work and time? Whoever carries out more time. Now let's go ahead and test your knowledge on these shared or split visits. All right, so we got a scenario. Dr. Lee and nurse practitioner Gomez both participated in a patient's E&M visit. Nurse practitioner Gomez spent 25 minutes reviewing the history, performing the exam, and documenting the findings. Dr. Lee spent 15 minutes discussing the management plan and approved it. The code selection is based on total time. Question: who should report the E&M service? A. Nurse practitioner Gomez should report the service because she spent the majority of the total time. B. Dr. Lee should report the service because he approved the management plan. C. Both should report the service together. Or D. Neither can report the service because the time was split. Okay, coders, somebody got it. Terica said, hey, it's NP Gomez. Good to see you, Terica. Brenda says the same. And you know what? Just because I'm calling you out doesn't mean it's the correct answer. I'm just happy to see you take the step. Trust me, if it's not right, you will learn something, and that is priceless. Good job. I'm going to let a few more people answer. And I just so you know, this is longer than an hour. This is scheduled for 2 hours. So stay as long as you can. There are no playbacks. So I do apologize for that. It's not a YouTube playback, only if you are a gold student. If you are a paid student, if you're in any of the paid courses, you'll see it. And also, not part 1. Oh, wait, yeah, it is in part 1. Also, if you have the MCG, if you got your MCG, it's going to be in there too. Not today, but tomorrow. All right, so if you have to jet out, if you are in any of those, you will see the playback. So all gold MCDC students, part any paid course, and MCG. Sure. Someone said, can alumni join Discord? Absolutely. Anyone can. All right. Time to answer this question. Okay. So the guideline says when the code selection is based on total time, the professional who spent most of the time takes precedence. And you can find it here. And that would mean that nurse practitioner Gomez gets to report the service because she spent the majority of the total time. All right, got another question. Okay, during a shared E&M visit, A, Wait, let's see this. It says a consult. Okay, come on, Chat GPT. What's up with this question? All right, so maybe I deleted something, but let's just say a physician consults with another physician about the patient. The nurse practitioner ordered and reviewed the labs, wrote the prescription, and consulted with the patient. The code level is based on medical decision making. Okay, coders, who is eligible to report the E&M service? So clearly, this is a split or shared visit. Is it A? Neither, because both contributed equally. B, the nurse practitioner, because she ordered and reviewed the labs, the data, that PDR, and she wrote the prescription, found that the risk. C, the physician, because he has the most experience. Or D, the physician, because he consulted with another physician, and that's a part of the data on that PDR chart. What say you? You all are rocking it. I see you, Vina. I see you, Melissa. I see you, Britters. Karina, I see you too. Yada, if I'm saying it wrong, you can spell it out phonetically and I'll try and shout you out and correct it. Shushma, Terika, outstanding job attempting. The correct answer is B, the nurse practitioner, because she ordered and reviewed the labs. That's data. And she also wrote the prescription. That's the risk. In fact, they do specify that when you carry out like two of those of the PDR problems, data and risk, if you carry out two of those elements, that is can be considered more substantive. So she clearly carried out more substantive part of the encounter. And you can find your guidance here. Now let's move on to question 3. A physician and qualified healthcare professional both participate in an E&M visit on the same day. The QHP reviewed the patient's history and the physician makes the final decision on the management plan and takes responsibility for the risks. Code level is based on medical decision making. Question: what does this indicate? Does it indicate A, the QHP should report the service because both participated? B, the physician has performed a substantive portion and may report the service. Or C, neither can report the service because the visit was shared. And D, the code level must be based on time, not medical decision making. What say you? Yeah, this one's kind of straightforward. It kind of leads you and it tells you, hey, the physician took responsibility, right? The answer is B. That physician performed a substantive portion and may report the service. He made the final decision on the management plan and takes responsibility for the risk. So the doctor performed a substantive portion of the PDR, the problems, data, and the risk. All right. So now I'm going to put up this PDR chart so you can answer it and hopefully it'll give you a little more guidance, right? So if you can answer any of these questions, did the doctor help to establish the problem that the patient had. And really, it's this data and risk that they are focusing on. Did any of the providers review anything? Did they order any tests? Did they, and that's pretty much it. Did they, was their assessment based on an independent historian, somebody other than the patient? And also, if any of these elements were carried out for the risk, this is what they want to know. Now, here's your scenario. A physician, oh, this is the same one, right? Yeah. Yeah, this is the same one, so I do apologize. I put this in here because I wanted you to know that this is what they were talking about. So for those of you that haven't studied E&M, you can, this is what we are talking about. We're talking about this chart. So I do apologize. Now, just want to end things with the main points. When you are talking about split or shared visits, these are visits that are shared by two people. And yeah, it could span a day. It could, as long as it's the same encounter. Not often does it span days, but anytime they share that visit, that doctor and that QHP, whoever does the substantive portion of the visit, they report the E&M service. Often that's your medical decision making. And finally, if the code selection is based on time, whoever spent the most time with the patient will report the visit. Now we're finished with share and split visit. Now let's talk about multiple visits on the same day. That's right, Miss Bianca. They nailed it. You all nailed it like pros. Now let's talk about when you have multiple visits on the same day. Remember, coders, the general guideline is you only code for one E&M visit per practice when they have the same specialty and subspecialty, per patient, per condition, per day. One E&M visit per practice, per patient, per condition, per day. When all of that is met, often you code one code. And where did you get that guideline from? Well, I got it from here where you see the multiple evaluation and management services on the same day. If you go up in the per day section and read it, that's what it says. And I think it's easier for you to remember it if you just have that statement, one E&M visit per practice per day, per condition per day. Because if it doesn't fall in there, then you can code more than one visit. All right. Now, location takes precedence. So if you have more than one visit a day, which one do you code? Well, the location of the visit takes precedence. There's a hierarchy. And I created this chart for you to see. And chart is based on guidelines and RVUs. So if you've ever seen the AMCI location chart, it looks a little different because the previous charts didn't consider RVUs, but this one does. Now, if you need to, this chart is brand spanking new. It's never been seen before. So if you want to screenshot it, go right ahead. And I just want to tell you that if this doctor sees a patient in all of these services, critical care will have the highest ranking, followed by admit and discharge on the same day, followed by consultation, inpatient consultation, followed by hospital inpatient and observation admission, followed by the ED, followed by office, followed by home residence, followed by nursing facility visits. Yeah. And then discharged and prolonged services, they're not applicable because you can code them with other encounters. But if all are considered, this is your hierarchy. But generally, you only code one E&M visit per practice, per patient, per day. However, if any of this is not met, let's say it's a different condition, then you can code two, right? And we're going to talk about that in a minute. All right, so there's your ranking. Pay attention to it. And we have an encounter. I want you to tell me, of the following answers, which best describes the encounter? A, 99214, 99284, 99214, 99284, and finally D, 99221. A Dr. Smith evaluated a patient in the office at 10 a.m. for chest pain, and it was moderate medical decision making. Later that same day, the patient presented to the ED department with worsening chest pain, where Dr. Smith again performed a full evaluation with moderate MDM. Of the following answers, which best describes the encounter? So we need to figure out, we know the guideline, one E&M per doctor or per group, per patient, per condition, per day. This is the same condition. It meets it. If it satisfies it. So we only can code one, right? Which one will we code? What say you? All right, so you all might not have enough time to look it up. So just type in the chat. Are you going to code the office visit, or are you going to code the ED visit? Which one? I kind of gave it away, right? So basically, Dr. Smith carried out an office visit at 10 a.m. Then later that day, Dr. Smith carried out a moderate emergency department visit, right? So the guideline says you can only code one E&M visit per practice, per patient, per condition, per day. So we can only code one. Which one do we code? Well, we're going to get rid of A because it's coding for two visits, right? Now let's use that chart that I created. If you have an ED visit and an office visit, you have to code the highest ranking one. So between ED and office, emergency ranks 5th, office ranks 6th, so ED is your highest rank. And if that's your highest rank, we have to code for the ED visit. Now let's go ahead and let's look up our codes. 99214 is your office visit. 99221, that's your initial hospital visit. And 99284, this is your ED visit, right? So 99284 is our answer. We're going to get rid of this 99221. That's an initial hospital. This patient was not admitted into the hospital, so we're going to get rid of you. We're going to get rid of the office, and we're only going to code for the ED visit, your moderate ED visit. And if you said C, outstanding. But if you've learned something, that's priceless, coders. It is. So I'm going to take a pause, and I just want to know, are you kind of understanding that the location takes precedence? The higher the location will determine which location you're going to code for. If a doctor sees a patient in more than one location, the highest will take precedence. Now, someone said, if the patient's seen by another provider in the ED, remember, we're only talking about one E&M visit per patient, per practice, per condition. So we're only talking about one practice, right? And we're only talking, and Dr. Smith is the same doctor, so we're still talking about the same practice. Hopefully that makes sense. I think through practice, you'll get it. You will. All right, we got another scenario. Of the following answers, which codes will the group use to code the encounter? Is it A, 99215 99222, B, 99222, C, 99232 99215, and D, 99232? And one thing I want to point out, coders, see this 99215? These are office visits. The lower it is, it's an office visits. Office visits range from 99201 through 99215. That's all you should remember. If you remember that, you're just giving yourself an advantage. So the lower 992s are office visits. And the lowest are new. And then the ones that come after that are established. So the '01 through '05, that's new. 11 through 15, that's established. Just thought I would tell you that. All right, a patient was seen by Dr. Green in the office for abdominal pain. Based on his findings and high MDM, Dr. Green advised the patient to go to the hospital, where the patient was admitted later that same day. While admitted, the patient was also evaluated by Dr. Mitchell, another physician from Dr. Green's group practice, who is of the same specialty and subspecialty. Dr. Mitchell completed a full battery of tests with moderate MDM. Of the following answers, which codes will the group use to code the encounter? Did I read these answers? I don't remember reading them. I'm going to read them. 99215, 99222, 99222, 99232, 99215, and D, 99232. Someone said, who admitted the patient? Well, we don't know who admitted the patient, but we know it's not Dr. Green or Dr. Mitchell. Good question. All right. So what we need to figure out, what's going on here? Dr. Green carried out a high medical decision-making office visit. Dr. Mitchell carried out a moderate hospital visit. And what I'm going to do, I'm going to remember my guideline because I know I can only code one E&M code per visit, one E&M visit per practice, per patient, per condition, per day, right? And I need to code the highest ranking of these visits because both of these doctors are in the same group practice. They share the same specialty and subspecialty, and they are treating the patient for the same condition, right? They're related. So I just have to code the highest of the two. So we know office visits are not higher than hospital inpatient visits, right? Hospital inpatient visits are 4, office visits are 6, right? Right. So we're not even coding for that office visit. Now we got a code for the hospital visit. So we're going to get rid of A and C because it's coding for 2 visits. Now, are we going to code for an initial visit or subsequent visit? Right? Are we going to code for an initial hospital visit or a subsequent hospital visit? Because this is the first time anyone from the practice is seeing this patient in the hospital. Even though we saw the patient in the office, that's null and void. So you know what? We have to code the initial visit. This is the first time anyone from that practice is seeing this patient. And therefore, that initial visit will take precedence. We're going to get rid of D, and B is our answer. You all are rocking it. Outstanding. That was kind of tricky. Some people might say, oh, that's the second visit. Nope. We got rid of that first visit. And this is the first visit. Okay. Now we have another scenario. Of the following answers, which best describes the coding for the group? How are they going to code this? A, 99215, 9923225, B, 99215, C, 99232, D, 99221, 99215, 25 modifier. A patient was seen in the office by Dr. Lee, a general practitioner for severe shortness of breath. Dr. Lee carried out an exam with high MDM, then sent the patient to the hospital where the patient was admitted. Shortly after admission on the same day, the patient was also evaluated by Dr. Patel, an oncologist from Dr. Lee's group practice, who carried out a moderate medical decision making. Okay, coders. So how is this group going to code or bill? What say you? Okay, coders, we might have some aha moments here. I'm excited. Great job getting that answer in the chat, coders. All right, so I'm going to use that little chart that we have, right? And I'm going to kind of modify the decision making tree chart because we have 2 doctors from the same practice. Dr. Lee is a general practitioner. He carried out a high MDM office visit. We have Dr. Patel, who's an oncologist from that exact same group. He carried out a moderate hospital visit. Now, the guideline is you only code one E&M code per practice if they have the same specialty and subspecialty, per patient, per condition, per day. I'm going to let that marinate. And when they don't, you get to code more than one often, right? I'm going to use this decision tree to determine if I can code for both Dr. Lee and Dr. Patel. Now, I kind of modified it a little bit because this decision tree is not for initial and subsequent, but it has the same mechanics. So I'm going to scratch out new and established patient, and I'm going to use this for initial and subsequent visit. And my question is, has this patient been seen by more than one doctor from the same practice on the same day? And the answer is yes. Do they have this exact same specialty? And the answer is no. No. So if they don't, one of those doctors, the last doctor, can code for that new patient. And I'm saying last because Dr. Patel, who saw the patient in the hospital, can code for a new visit because he doesn't have the exact same specialty and subspecialty as Dr. Lee. Are you with me? All right. So we can just get rid of this office visit here, this 99215, right? And we can also get rid of this 99232 because we can code for both of these doctors, both of these visits, because they don't satisfy this guideline, right? We can code for them both, right? Now, the difference between A and D is the sequencing, right? Yeah. So essentially, they're sequencing the office visit first with A, and D, they're sequencing the office visit second. And the secondary code is a hospital visit, and this one is also a hospital visit, but this is a hospital subsequent visit, and this is a hospital initial visit. So off bat, I know I can code D, but if we need that extra guidance, you can just look at your ranking chart and see that you would never sequence your office visit before your hospital visit, right? Because office ranks 6, hospital ranks 4, and right away we know we can eliminate A because it's wrong. So that's just kind of like a test taking tip that I thought I would share. And your answer? Your answer is going to be D. And we've looked up this code already today, and we know 99221, this is the code for initial hospital visit, and 99215, this is the code for a subsequent office visit of high complexity. And we placed that modifier 25 to denote that these two encounters are significantly separate from one another. I love it. Someone said, hello, brain. All right, somebody said, hey, should this be 99222 since it was moderate MDM? I believe so. If 99222 is moderate, they kind of split them. So don't get me over here looking because I am pulling it up now. Can you all look it up and let me know, is 99221, I thought it was low to moderate. That's just off my memory. Go ahead, type in the chat. I can't see you because I'm looking it up too. It is low. That's straightforward to low. So you're right. It would be 99222. However, between the two, D is the best of the two because A is coding for a subsequent visit. Very good, very good, very good. All right, thank you for that catch. Great forensics, and the answer is D. And remember this, coders, your job is to pick the best of the four, right? When you're taking your exam, pick the best of the four. And don't get caught up if you see something wrong, because everyone is human, including AI. All right, so I believe this is the last one, and then we're going to move on to our next subject of the following answers, which best describes the encounter. A, code all three visits. B, code the ED and hospital visit. C, code the ED visit. Or D, code the hospital visit. Mr. Jones was evaluated by Dr. Adams in the ED department at 8 a.m. for worsening abdominal pain. After evaluation and diagnostics, Dr. Adams sent the patient to the office clinic across the street where he saw the patient at 11 a.m. for further review and pain management planning. By 3 p.m., the pain had worsened again, and Dr. Adams admitted the patient to the hospital for the same condition. Okay, coders, of the following answers, which best describes the encounter? Okay, I don't see any answers in the chat, but I do see a question which I'll answer shortly. And yes, those answers are coming through. So essentially, coders, this Dr. Adams saw this patient 3 times in one day, and they want to know, what do you do? Dr. Adams saw him in the ED, OV, office visit, and hospital visit. So if you have all three, which one do you code? Well, does it meet this guideline? It does. Dr. Adams saw Mr. Jones for all of the same condition. It's the same condition, same doctor, same patient, so we only can code one. So we're not going to code, ooh, we're not going to code all three visits, right? We're not going to code the ED and the hospital visit. We're only going to code one. And you just look at your chart, which one is the highest ranking? And the highest ranking is going to be your office visit. You all nailed it. You nailed it. Thank you, JJ. And the answer is D, hospital office visit. Excuse me, hospital visit. Woo, hospital visit. Hey, there are offices in hospitals. And the answer is D. Now, how do you feel, coders? You feeling good? All right. So somebody asked a good question. They said, hey, back in that other scenario, how did you know that was an established visit? Okay, coders, this is universal. When you're taking your exam, if it doesn't specify if it's new or established, it's established. When you're taking your exam, if it doesn't specify if it's new or established, it will be established. Why? Because that is the lowest RVU, and that's just pretty much the way it is. If somebody's going to the doctor, going to see their PCP, et cetera, and it doesn't say, oh, you've been here 3 years, and, it doesn't list that, the presumption is that it's established. It's when they're new that the language will specify or document that it is new. So that's kind of like a little tip. So if someone's going to see their CPC, it's established. All right. So now, did you know, and like everything in E&M coding, when you have multiple visits on the same date, there are guideline nuances. There are nuances. There are circumstances that kind of don't fit neatly into that one E&M code per practice, per patient, per day, per condition, per day. And here they are. They're addressed in your guidelines when you have multiple evaluation and management services on the same date, right? They have guidelines describing, oh, let's go back. They have guidelines describing per day, and we've already looked at that. They have guidelines when you have multiple encounters in different settings or facilities. When you have an encounter in the ED and services in another setting, what to do. When you're discharged services and you have services in another facility. So if a patient is discharged in one facility and they have services in another facility and the doctor visits them, what to do. When the doctor carries out discharge services in one civil in the same facility. So if they carry out discharge services in hospital A and then some more services in that same facility, what to do. When a patient is discharged in one facility and admitted, or excuse me, and other services in another facility, what to do. When a patient has critical care services, what to do. When a patient transitions between office or other outpatient hospital, home residence, or emergency department, and to the hospital or nursing facility, what do? This is what you do. You get that location chart and you pay attention to this last column, right? So when you have critical care, you can code it with other encounters. When you have a discharge um, service, you can code it with another encounter. And when you have prolonged services, you can code them with other E&M locations, right? So just pay attention to that last column whenever you have any nuances. And also, those guidelines that we've just seen, I put them in a chart because I see things better that way, and hopefully you do too. So when you have multiple visits in the same location, we know that generally one E&M code per doctor per day, and you can add up the time if it's multiple visits that and all of them were time based. You can add it up, and you can also add up the MDM aggregate to bump up the level of service. You can. That guideline says it. Also, when you have multiple visits in different facilities and different locations, just remember you can only use time once if it's different. And if you have an intra-facility transfer, that is a single visit, right? So if it's within the facility and they're transferred in that facility, it's one visit. If they're going from the ED to other facilities and locations, when the patient's admitted into the hospital, you only code the inpatient admission, and you may combine the time of the ED visit and the inpatient visit. Also, if a patient's discharged from one facility, well, from facility A and readmitted in facility A, if that happens, you report it as one visit, and that's a subsequent visit. The subsequent visit, okay? It can't be an initial visit. It's a subsequent visit. Now, if a patient is discharged from discharged from one facility and then seen in a different facility, you can report them separately as long as the time spent discharging is not shared. Now, if the patient's discharged and then receive service in other facilities and locations, you can report those separately too, as long as the time spent discharging is not shared. And when a doctor renders critical care, you may code critical care with other E&M visits. However, you'll need to follow the guidelines for critical care, NICU, and PICU. Make sure you pay attention to those guidelines. And finally, when a patient transitions from office, outpatient, nursing, residence, ED to the hospital or nursing facility, you're only going to code the hospital or the nursing facility. So those are just little nuances that CPT felt was important enough that they mention it and they provide guidance. Now, we're going to use we're going to use that chart and we're going to test your knowledge of the guideline. So when you have multiple E&M encounters on the same day and you got some nuances, and here's one. How should this be reported? Dr. Patel sees a patient twice on September 15th in the hospital inpatient setting. The first visit is in the morning and the second is in the evening to reassess after the test results. What do you do? A, report only the morning visit as an E&M service. B, report two separate E&M services for each visit. C, do not report any E&M service since both visits occurred at the same day. Or D, report a single E&M service using aggregated MDM or time. OMG. OMG, you all nailed it. Outstanding. Yes. You report one E&M code, but you can add up the time or the MDM. You can do the aggregated MDM, like use elements from one of the encounters and the other, and it'll help give you a higher level of service. So the answer is D. Now, these probably will be applicable in the real world. When you take this exam, they just really want to make sure that you understand you can code one E&M code per doctor per day of some subspecialty and specialty. Great job. D is the answer. All right, we're going to pick up the pace. All right, a patient is discharged from the hospital in the morning after recovery from pneumonia. The provider documented 25 minutes spent on discharge management. Later that afternoon, the patient's admitted to a skilled nursing facility for continued IV antibiotic therapy. Both visits occurred on the same calendar date. Of the following answers, which best describes the encounter? A, 99238 and 99304. B, 99239 and 99304. C, 99238 only. D, 99239 only. And E, 99304 only. Sorry about that. What say you? Take your time. Okay, let's see what we're going to do. First, we got to figure out which guideline we're going to follow. And we see a discharge happen. So it's one of these three. What happened? Well, this patient was discharged from the facility, then admitted to a different facility. All right. So the patient was discharged from a hospital in the morning, then admitted to a skilled nursing facility. So what do? It says it may be reported separately as long as the time spent discharging is not shared. And it doesn't seem like that. Discharge services is a little different, and they were providing IV antibiotic therapy. And it says we can code both. So I'm going to eliminate C, D, and E because it's coding for one visit. So we know we can code for two. Let's take a look at 9923839 and 99304. 99238, this is the hospital inpatient or observation discharge day management, 30 minutes or less. So in our encounter, we had 25 minutes spent. So 30 minutes seems to be in our wheelhouse. This 99239 is more than 30. So I like the 99238, and I also like the initial nursing facility visit, 99304. So we're going to get rid of B, and our answer is A. And if you said A, outstanding. But if you learned something, that's priceless. All right, we got another one. Can the time spent in the ED be included in the inpatient E&M code selection? Dr. Nguyen or Gwen sees a patient in the ED and later admits the patient to inpatient care on the same calendar date. Can Dr. Nguyen code for both? Yes. If ED services are not reported and the time contributes to the inpatient services. B. Yes, but only if the ED visit was documented separately. C. No, because the ED and inpatient settings are different. Or D. No, if the patient is admitted from the ED to the same hospital, only code the hospital admission. What say you? You all are rocking it, and I want to draw your attention to this last one. They specifically state that transitions between office, home, residence, and ED to the inpatient, you only code for the inpatient encounter, either the hospital or the nursing facility. You cannot code both. So they're very specific about those transitions. And if you said D, outstanding. We got another one. Question 4. A patient's discharged from a hospital and readmitted to the same hospital later that day. How should the physician report the service? A. Report only the discharge service. B. Report a subsequent care service instead of discharge or initial service. C. Report both discharge and initial admission services. Or D. Do not report any E&M service for that day. Hmm. What say you? You all are rocking. You are rocking it. And I see somebody else. Jolisha, way to go. Great job, Melissa. Great job, Shushma, Vina. Tiffany, great job. We're going to follow the discharge and readmission to the same hospital. When that happens, it's seen as one stay and report as a subsequent visit. So B is the correct answer. And if you said B, way to go, way to go, way to go. I see you, Miss Brenda. All right, I believe this is the last one. Dr. Thomas provides two E&M services on the same day, one in the hospital and one in a separate outpatient clinic. Time-based coding is used for both encounters. How should time be allocated? A, only code the outpatient clinic. Only the outpatient clinic time should be used for code selection. Total time for both services can be combined to select one code. C, time must be allocated separately for each service and no time can be counted twice. Or D, only the hospital time should be coded, should be used for code selection. Okay. What say you? This is a trick question. Thanks, Chat GPT. Okay, okay. I think you all, some of you, well, at least one of you was not fooled, right? Hmm. Let's see. Wait a minute. I don't think the correct answer is here. I don't think the correct answer is here. Because, okay, I'm going to use guideline, the second one, when you have multiple visits in different facilities and locations, right? So if you have multiple visits in different facilities and location, it says time can be used only once. Intra-facility transfers is a single visit. So this is not intra-facility. This is a separate outpatient clinic and hospital. So they're not the same facility or different facilities. It says time can only be used once. Now, A is saying you can only code for the outpatient clinic. And that is technically correct. But how do we know which one has higher RVU? How do we know? Right? Oh, one in a hospital and one in an outpatient clinic. So this is wrong. Now, total time for both services can be combined to select one code. That is not permitted, right? So the guideline says time can only be used once. Now, C says time must be allocated separately for each service and no time can be counted twice. I think C is the best of the answers, and D, only the hospital time should be used for code selection. So I believe C is the best of the answers, but I don't like it. So are you all with me? Time may be allocated separately for each service, and no time can be counted twice. So time only used once. You all with me? I see a lot of D's like, hey, you know what? I might like your D, but chat's job was to give me an example of C. So let's see. I think I like D better. Chat, you failed on this one. I'm going to go with D2 because you have a hospital visit and an outpatient clinic. That's an office and a hospital. And this transition between office and hospital, you're going to code the hospital. I like D. Way to go. Yeah, I like D. Hats off, hats off, hats off. Good job, coders. You all, you all did better than chat AI. That's why they need AI. That's why they need coders. This is exactly why they need us. So I'm going to change it. I want to make sure my answer is correct. Okay, we're down to the wire. We're going to finish up. First of all, I just want to really shout you out for this one. Thank you so much. All right, I've changed it on my end. And we're just going to conclude that this chart really helps when you have multiple visits and you have those nuances. This column on the right can be helpful. It'll let you know if you can code a visit, multiple visits on the same day. Now, whew, significantly separate encounters. You know that modifier 25? Well, CPT has a section for services reported separately. And here are the main points. The main points are when you have a procedure performed and it has its own CPT code, it can be reported separately. It does not count towards the level of E&M service. And the modifier you'll use is modifier 25. When you have diagnostic tests and they're ordered and interpreted, remember that PDR, the data, can it be reported separately? Yes, it can if it's ordered and interpreted, keyword interpreted, and it will not count towards your E&M level. And you will append modifier 26 if the doctor, the professional, carried out the professional component of that test, such as interpreting it. Now, if diagnostic tests were ordered but not reviewed, then that's a different story. No, it can't be separately reported. And yes, it counts towards the MDM, the data section. And you don't append any modifier when a provider carries out diagnostic tests when they order it. And finally, when E&M services are distinct from a procedure, anytime your E&M service is distinct, yes, it's reported separately. Yes, it can count towards the E&M level, and you do append modifier 25. So this little chart kind of summarized this guideline. And you know what? We're going to use this chart to answer some questions, but I do want to draw your attention to using modifier 25. You use this modifier 25 for a significantly separate identifiable E&M service, and you use modifier 26 for professional diagnostic tests services. So when the doctor is carrying out that professional component of a test. Now, this is the chart. I just came up with this chart today. So it might look a little crazy and you might see a little fumble. There's a couple of things I want to change on this chart, but this is the initial. This is the first time anyone's ever seen it, even my team. So hopefully this chart helps you understand if you need to, code it separately or count it towards the E&M level, that MDM, that PDR. And we're going to go ahead and test your knowledge on separate procedures. All right, is this a separate procedure? How would this be reported? Dr. Allen performs a minor skin lesion removal in the office. The patient was not seen by the physician prior about this condition. The patient also received a full evaluation prior to the decision to remove this lesion. How should it be reported? A, report both the procedure and the E&M code with modifier 25 on the E&M code. B, report both codes without any modifiers. C, report only the E&M code. D, report only the procedure code. What say you? Type your answers in the chat. Okay, let's see. All right, so we got A, D, and C. Let's see. I'm going to use this chart, and I want to let you know that this E&M service is distinct from the procedure. This patient came in. The reason for the encounter was not to remove the lesion. The reason for the encounter is the doctor visit. The doctor never saw the patient. The doctor didn't know about this lesion, right? No, the decision to remove that lesion took place during that encounter. So, this evaluation and management service is distinctly different from that procedure. So, you can report both and append modifier 25 on your evaluation and management code. Now, if the patient comes in for the removal of the lesion, then you better believe you just go ahead and combine the two because it's not distinctly different. All right? So your answer is A. How should this be reported? Dr. Rivera orders and interprets a chest x-ray during an office visit. She writes a separate signed report for the interpretation. Okay. A, report the E&M code only. B, report X-ray CPT code with modifier 26 and the E&M code. C, include the X-ray interpretation in the E&M code. Or D, report only the X-ray CPT code. What say you? I'm going to put these up so that you can reference and type your answers in the chat. Okay. So as you can see, the key word is interpretation. When a provider is carrying out interpretation, and they're interpreting an X-ray. They are carrying out the professional component of that X-ray. Yeah, to interpret it is a lot more than reviewing it. Just thought I would let you know that. So we're going to follow this guidance. When the doctor has ordered and interpreted a report, it can be coded separately. It does not count towards the E&M level on that PDR chart, and you do append modifier 26 on that diagnostic test. So the answer is B. Report the X-ray CPT code with modifier 26 and the E&M code. You can code both. So if you said B, outstanding. And if you learned something, that is priceless. Okay, Mrs. J, look, I got to get myself pumped up because I am kind of fading a little bit. All right, let's go. How should this be considered in E&M coding? A nurse practitioner reviews lab results during a patient visit. The results are used to formulate the management plan. The lab tests were not interpreted separately. What do you do? A, the lab results must be counted as data reviewed for the MDM. B, the lab results must be reported separately with the CPT code. C, the lab results count as an independent interpretation. Or D, the lab results are not counted towards the E&M coding. What say you? I think you all just nailed it. Yes, it's A. The lab results can be counted as data. If you go to the third one, diagnostic tests ordered, and yes, it can be counted. And this is the part of the chart that I need to fix because this should say diagnostic tests ordered and reviewed. So if the provider orders the tests and reviews the tests, it cannot be reported separately and it does count towards the MDM, the data, right? So if you're talking about data, this column here, it shows you review of the test results. That's one of the elements. Ordering of the test results, that's another. And as you can see, it is a part of the medical decision making. So if you said A, way to go, way to go, way to go. All right, coders. This is my chart. I'm going to adjust it and I'm going to put it, where am I going to put it? I'll probably put it in the description of this video. You only can watch this playback if you're in a paid course. If you're a gold member, if you purchase the MCG, if you're in the MCDC, if you're in any AMCI paid course, you can find this chart. So all of these charts will be placed in there for you. Okay, so this pretty much concludes our presentation of a study, a deep dive of the evaluation and management guidelines. We reviewed new versus established patients, initial versus subsequent encounters, shared and split visits, multiple visits during one encounter, what to do, separate procedures. And this is it. Thank you so much for taking the time to kind of hang out with us and, you know, allow us to share with you our new instruction on guidelines for evaluation and management. It was incredible, and this was impromptu. So I need to know. I don't know if you can click on this. Let me know if this is clickable. But if you all can just kind of complete the survey and let us know if you learned something, if there's something that we may have missed, and what are your thoughts on today's session? I would love to know. And I just want to thank you. I do. You all did an incredible job. So if you can't click on that link, if you can copy and paste it in your browser, that will help me tremendously. And also, coders, please, if you can, like this video. If you liked it, right? All right, so if you have any questions, go ahead. I'm here. I want to stick around and answer any questions. Thank you so much. Kimmy, you were incredible. Way to just, you know, way to do it. And I thank you all for just really staying the course, staying it, not being distracted. I did get distracted by some of the stuff AI did, and I'm like, I thought some of the questions were a little more complex than they needed to be. But I do appreciate you all for hanging in there. Jaleisha, you have an awesome day. Tiffany, thank you. You too. Christine, amazing. Someone said they want to see the big color chart. I will do that, but you know what? You really can't see it. And it's not the full chart. It's just what is it? It's just like one segment of it. This. Let me see if I can take this off. But you really can't. It's so blurry. But if you have an MCG, it is in there, and it's a much, much better, higher resonance copy. But I'm going to tell you, if you kind of get it, you don't need this. You can just look at the chart in your CPT manual. Someone said, can I do a video on orthopedic coding? If I have time, I will. That's musculoskeletal. So yeah, I don't mind doing it. But right now we're finishing up our E&M. We're getting the MCG ready for 2026. And if I can find some time, I will. But I tell you one thing, I am working on a PCS. I'm working on PCS too. That is highest on the priority, but definitely check out our musculoskeletal section. Check out those videos. Just kind of go in the search of the AMCI channel and search musculoskeletal. You're going to get a lot of stuff. Thank you, Pamela. And before I go, you know who I want to thank? I want to thank my team. Miss Bianca, Miss Dolly, Ms. Mills. Who else did I see? And if I missed you, I apologize. But I want to thank my team. They are the best. All right. So if you have any questions, go ahead and write them on the survey. I think there's a section. You can write your question there. Okay? Copy and paste in your browser. Okay, everyone. Good. Someone said they had fun. That's what I'm talking about. And this is not the fun stuff. It's guidelines, right? So, thank you all. And I want you to have an enjoyable rest of your day. Take care now.